Welcome to the L-Nutra Longevity Lab series, where science meets strategy for a longer, healthier life. I'm Renee Fitton, your host, longevity dietitian, and director of education at L-Nutra. Every episode, we explore the latest research, expert insights, and practical tools to help you harness the power of fasting, nutrition, and longevity science. Whether you're new to wellness or you're looking to expand your expertise, we're here to empower you with knowledge that supports vibrant and lasting health. Today, I am thrilled to be joined by Dr. Ken Sharlin, board-certified neurologist, functional medicine expert, and founder of Sharlin Health and Neurology. Dr. Sharlin is internationally recognized for his work helping patients reverse cognitive decline using his comprehensive brain tune-up protocol, a science-based program that combines advanced diagnostics, personalized nutrition, neuroplasticity training, and metabolic therapies to restore brain function and improve quality of life. Don't worry, we will be getting into all of those things soon. He's one of the few neurologists in the world deeply integrating functional medicine and neurology, making today's conversation especially exciting. So Dr. Sharlin, thank you so much for joining our Longevity Lab. Your journey from conventional neurology to pioneering functional and regenerative neurology has been very impressive. I had a chance to dig into it. Can you just share a little bit about what inspired this evolution?
Yes, absolutely. And thank you for having me. I'm really looking forward to this conversation. Well, I actually have a very traditional background, very academic education, having gone through medical school at Emory University in Atlanta and then up to the University of Virginia and finally Vanderbilt University, where I finished my training in neurology. So I really believe in, was sort of trained to believe in the message of traditional medicine. Our friend Mark Hyman might say the pill for the ill approach, right? You make the diagnosis, you find the right drug to treat that diagnosis. And I did that for a number of years. But like many physicians, I became rather disillusioned with that approach and realized that my patients were really just getting sicker. And I was kind of putting a Band-Aid over a problem. But if you put a Band-Aid over an infection, you might be hiding the infection, but the infection's still getting worse. And then you have a disaster on your hands. So I knew I had to find a better way. And fortunately, about simultaneous with that experience, I became a endurance athlete. I became a triathlete and long distance cyclist. And because I like to geek out on things, which is sort of what our whole podcast here is about, right? It's the science, what's under the hood, right? And I knew that, having a good workout was only part of the plan, so to speak, that ultimately to do something like the Ironman triathlon, I had to focus on nutrition. I had to make sure my sleep was dialed in. I had to understand that these workouts were a huge physical stress on my body, and I had to measure that stress in some way and know if I was training the right way, if I was overtrained, if I needed to rest, and so forth. And as I learned more and more about that, I thought, well, really fundamentally, these are the principles of health, whether that's brain health or heart health and so forth, and that somehow I needed to merge my private life with my professional life and bring these principles into the clinic. And I was lucky that in all of that goings around, I was listening to podcasts as well. And lo and behold, Dr. Dave Perlmutter was being interviewed, and he talked about functional medicine. And I sort of said, what's that? Of course, I could look it up. And, it was like the gates of heaven opened. I saw the angels and the trumpets and the choir and and I thought, I have found my home. And so I quickly changed my direction and became a certified functional medicine physician through the Institute for Functional Medicine and quit my job as an employed neurologist to open my own practice now 10 years ago and really bring these principles into the practice of traditional neurology.
Incredible. And thank goodness that you found those gates of heaven open up for you, because now we all get to benefit from you merging these two avenues together, which unfortunately, as I mentioned in the intro, it's very uncommon that we're really seeing these two areas coming together. And when we think about things like early Alzheimer's and some of these neurological conditions, a lot of people are saying there's not really much you can do in terms of prevention. And that still seems to be a lot of the prevailing narrative. So you published recently an article titled Reversal of Cognitive Decline. You share that even early Alzheimer's and these cognitive decline can in fact be reversed. So can you share a little bit about what you've noticed in terms of some of these contributors to cognitive decline and how lifestyle and nutrition you've found can support in prevention and ideally even reversal once it's already started?
Yes. And, time flies. That paper was 7 years ago. So it was 2018, and a lot has changed since then. So I hope we get to talk about that too. And I will say that I've always kept, one foot in academics, in research. I have a large research site. We were instrumental in bringing what is now called Kisunla or donanemab from Eli Lilly to market, which is the second of two disease-modifying therapies that are approved for Alzheimer's disease. But unfortunately, while I think it is a step in the right direction, these treatments do have serious considerations. They are almost uniformly, meaning if you were to choose to have this treatment, you should count on the possibility of a serious side effect that is called amyloid-related imaging abnormalities, or ARIA for short, which results in potentially little bleeds in the brain or areas of swelling that most of the time do resolve, and most of the time are more imaging-related abnormalities, meaning they don't really affect the person in any way that they can measure, but nevertheless, it can be serious at times, and these drugs really need to be monitored. And at best, they only slow the progression of decline. They do not reverse decline. So we have a long way to go. That being said, academicians, those who dedicate their entire career to whether it's Alzheimer's, Parkinson's, MS, and so forth, have been talking for some time about the impact of lifestyle. We know about the MIND diet, for example. There are studies of exercise in Parkinson's disease. There's lots of research about sleep and disrupted sleep, for example, obstructive sleep apnea, and how much that raises the risk of neurodegenerative disorders such as Parkinson's and Alzheimer's. The tragedy, in my opinion, is that there's a big divide between what we might read in a journal, what someone is studying, which in reality, they're sort of studying it either in a controlled environment, meaning they're doing a research study, right? It's very controlled, very rigid, but most people are not doing it in the clinic. Most people are not bringing these principles into the everyday practice of medicine and certainly neurology. So when I go to the big Parkinson's meetings and someone gets up on the podium in front of 5,000, scientists and neurologists and so forth, and the audience and says, we think that mindfulness-based meditation might just help Parkinson's, it sounds very theoretical. And that's really a shame, because if we go back to the work of people like Dean Ornish, people like, of course, Walter Longo, but his predecessor, who I love the whole story of Dr. Roy Walford. This information has been known for over 100 years, that modest calorie restriction increases longevity. So my question is, why is it that we have to wait this long for your average everyday physician to start implementing these in daily practice and really make huge differences in people's lives?
Absolutely. And thankfully, I think we are starting to hear more of these publications come out and people are starting to latch on to them a little bit more. I think people are now becoming especially more open to lifestyle as additive to, more of our traditional therapies. And so you mentioned briefly nutrition, you mentioned sleep. I know I've been hearing a lot around exercise and cognitive health. Are there other areas that you would consider pillars as lifestyle areas to focus on for cognitive health?
Absolutely. Well, and going back to that paper, was very fortunate that when I made that commitment that I was going to practice in a certain way, I knew that there were a few thought leaders out there, and I wanted to make sure that I was connected to their work. And what I mean by that is that people were specifically working in the area of neurology. So I connected with Dr. Dale Bredesen, who at that time was just starting to, make public his Bredesen protocol recode. He did not have any software. He did not have, sort of his minions. I went out to Novato and met him, and he has a beautiful Buck Institute designed by I.M. Pei out there and all his labs and so forth. So this was very, very, very early on. But, his work resonated with me. It was really functional medicine applied to brain health and specifically Alzheimer's disease. And so I went back and I started implementing some of the principles that I had learned out in California. And that's when we partnered on our paper. What has happened is that I was one of the lead authors. I was essentially the lead author. Dr. Bredesen put himself first, but I contributed the patients, the subjects, and about a third of them, about 36 of the 100 were ours. And at the time, we were using those foundational medicine principles. So it was sleep, it was movement, nutrition, what I call a stress resilience practice. It was, in some cases, connection or relationships, socialization, which is very important. And then the other piece of it is often hormone optimization, because a lot of people don't necessarily know, not only is Alzheimer's disease a female predominant disorder, meaning that 2 out of 3 people affected by Alzheimer's are women, but women who get on hormone replacement therapy are in fact protecting their brains, reducing the risk of Alzheimer's disease. The converse is also true, especially women who go through early menopause. So if they've had their ovaries and uterus removed surgically, I've seen it happen as early as mid-30s. I'm sure it's happened in younger women in certain situations. And the doctors say, well, you don't really need hormones. Oh, yes, you do. And so when you optimize those hormones, ideally get started early, stay on them, and ignore all of the mythology about, oh my gosh, it's going to give you heart attacks and cancer and blood clots, which is a whole separate discussion, but let me just say a bunch of nonsense, that we can make a huge difference in how people's brains work. So we didn't have in 2018 biological markers that were very practical, meaning that even then, I, as a neurologist, am a very hands-on doctor. If I wanted to confirm that a person had the pathology, the changes in their brain that we would recognize as Alzheimer's disease, I would do a spinal fluid examination, which is pretty straightforward procedure to a neurologist. And a lot of people, they're worried, won't that paralyze me and all that stuff? No, it's really, we use numbing medicine. You just lie on your back. We do it in the office. But still, most people don't want to volunteer for multiple lumbar punctures. So we could use it diagnostically, and we're looking for the amyloid beta protein and the tau protein, but we couldn't really use it, practically speaking, to track treatment over time, only because either the insurance wasn't going to pay for it, or not too many people going, oh, me, I want to do a lumbar puncture every 3 months. But we did track clinical outcomes. So we used something called the Montreal Cognitive Assessment, or MoCA for short. It's a very doable cognitive screening tool, and we could track improvement over time. And I think our patients on average improved about 3 points on the MoCA, but I had people going from, say, just for reference, this is a test where the maximum score is 30. Technically, 20-30 is considered normal. One of the categories is delayed recall, and that has a possible 5 points. So my opinion is that if you have 26 out of 30, but you lost those 4 points on delayed recall, it really is a problem. It's not just technically normal because 26 to 30 is normal, right? But we had patients who were going from scores like 18 up to 25, 26. So 3 was the average, but we had people doing even better than that.
That's incredible. And you kind of answered one of my questions, which was what types of diagnostics are you using in your practice to assess cognitive health? You mentioned MoCA, you mentioned the spinal fluid exam, which sounds like you don't use it very often. But are there other types of diagnostics that you're using? Jumping off from that question, at what point should somebody be doing these diagnostics? Should somebody be coming at you at 18, 30, 50 when they notice some sort of cognitive decline? When are you prompted to use these diagnostics?
So, fast forward, we are now in the age of biological markers. This is part of precision medicine. And the push is to have blood based biological markers. We could do, in some cases, saliva, urine, stool, depending on what we're interested in, of course. But by and large, people are used to getting blood tests. It's not always comfortable, but it's not the end of the world to get a blood test. And so now we can use these blood-based biological markers not only to confirm the suspected diagnosis of Alzheimer's disease, but to track those changes over time. Now, I don't mean to see people get worse, because that's not why people come to see me. I expect them to improve over time. And then I'm looking over my shoulder because I do have this. There's a company, and believe me, I don't get paid to do this. So no paid, this is not a paid promotion. But there's a company that was a spinoff of some research out of Washington University in St. Louis. And when it was commercialized and privatized, it's called C2N Diagnostics, Charlie, the number 2, N as in Nancy, Diagnostics. And they have developed a blood-based biomarker test called the Precivity AD2 test. There was a Precivity AD first, but the Precivity AD2 test is a better test. It's more accurate. It's more predictive. It's been validated against what's called the gold standard. So the gold standard would be spinal fluid or something called a amyloid PET scan. But I don't order amyloid PET scans because I can do a Precivity test, right? It means that it's as accurate as an amyloid PET scan. It's as accurate as a spinal fluid test without the inconvenience or discomfort of the test. So we can do the test in the beginning, put the patient on have the patient engaged in the plan, and then every 3 or 6 months, depending on the situation, I can repeat the test. So I have blocked out this person's, we use the term redacted, the person's name, but this test, I'm going to put it in the camera because people will get ready to have your mind blown, as the sort of expression goes. So this test was done on the 5th of October, 2024. And you don't have to be, a super scientist to see what positive means. This person has Alzheimer's disease. Positive. Okay. All right. Fast forward 6 months, April 15th, 2025. What does that say?
Wow. Negative.
Same person, I promise you. So these things are possible, and it is very unfortunate. I'm going to take a dig at the Alzheimer's Association because they are really directly responsible for this, business about the only disease for which there is no treatment, no cure. Yes, there is, folks. Absolutely, there are things that you can do to improve your brain. And now, unlike that paper from 2018, you can not only show that your memory is improving in real world situations, but we can show you that your disease is in fact regressing or in remission.
That is incredible. And it's so wonderful to see that this is now able to be tested through blood so much more readily available. Now, I'm curious, you mentioned that this is an amyloid. It's primarily, it sounds like, measuring for amyloid. Is it measuring for other things beyond amyloid? And to jump off from that, knowing that it is amyloid specific, is it also able to assess things outside of Alzheimer's and other cognitive areas of concern?
So to be clear, the test integrates 3 individual markers. It does include the amyloid beta 42. So for folks who are not I know you're a scientist, but for folks who might be listening, in the brain and people who have Alzheimer's disease, there are two things that can be seen under the microscope. We used to call them plaques and tangles. The plaques are composed of a protein called amyloid beta 42 that has been misfolded and is insoluble, meaning it just accumulates and accumulates. And it appears, for the most part, that the main driver of this amyloid accumulation is things that trigger an inflammatory response in the brain. So in a sense, amyloid is really a reflection of chronic inflammation. Now, in the Precivitytest, they calculate a ratio called the amyloid beta 42 to 40 ratio. So there are other forms of amyloid, one that is 40 amino acids long, that is different from the 42 amino acid amyloid associated with Alzheimer's disease. There's another marker called the phosphorylated tau 217. We call it p-tau for short, p-tau 217. And this is probably the single most important individual biomarker out there for Alzheimer's. But by combining the p-tau 217, which is more a marker of damage to brain tissue, degeneration, loss of brain cells. It comes from something called the microtubule assembly, which basically, if you want to think of like train tracks, and I always think of the old-fashioned, the guys who are doing this, in the old movies, the silent movies or whatever, Laurel and Hardy or whatever. Anyway, the brain cell has a kind of a big head, we call it the cell body, and a long tail, but it's all alive. So it all has to receive nutrients, right? And so the cell body has to send stuff down to the other end of the cell along this long arm called the axon. And it does so along these train tracks, if you will, called the microtubules. And as the cell is damaged and falls apart and sort of spills its guts, if you will, this tau protein just spills out into the brain tissue. So again, one is a marker of inflammation. Sorry, I lose my breath. One's a marker of inflammation. One is a marker of degeneration. I think it's really important because, for example, I saw one of my patients today, and he has what's called early onset Alzheimer's. This guy, he's a Marine. He looks like a Marine. He's very handsome, very buffed, short haircut, blah, blah, blah. He has familial Alzheimer's, basically. And we've been working with him. And these can be very tough cases. And he's done very well. We've worked with him for probably a year and a half, maybe 2 years. Really hasn't declined. He's improved. And we went over his Precivitytest today because I have him on an investigational treatment. And on the surface, I said, I shouldn't say his name, but let's just say his name is Robert. I said, Robert, I want you to hang in here with me while I show you this test result because it's abnormal. And I don't want you to be disappointed by that because it's a positive test, but we expect it to be positive. I said, but let's dig into the numbers here. And when he first started with me, this test wasn't available. So we're kind of getting in late with the test with him, and we're going to use it to moving forward to track. But as we got into the tau levels and the amyloid 42 to 40 ratio, his 42 to 40 ratio was normal. I said, look, I don't know what it would have been 2 years ago, whatever, but he is following that anti-inflammatory diet and lifestyle program. He's optimizing his hormones. He's on an investigational treatment that I'm pioneering that is adjunct to everything else we do because it's all important. And right now, his amyloid levels would not meet diagnostic criteria for Alzheimer's. He does have the neurodegeneration piece. His tau levels are a little bit elevated, not actually all that bad. But if you, for example, had a bad cut that eventually healed, you might have a scar. That's possible, right? So we can see evidence. Oh, did you hurt yourself? Yeah, many years ago, I hurt myself, right? So he has some of those changes of degeneration. But the remarkable thing is the anti-inflammatory approach, this diet and lifestyle and some of these regenerative principles have a profound and measurable effect on Alzheimer's.
Wow. I think now what the next obvious question is to really dig into some of these principles, these anti-inflammatory principles that you're leveraging and learning a little bit more about how you're getting people from these positive to negative results on these tests. So why don't we start? Of course, I'm going to pick starting with nutrition. Can you share a little bit more? I mean, you mentioned Dr. Bredesen. I know he's a little bit more ketogenic friendly. Is that what you're also seeing in your practice? What is your general nutrition guidance?
Think as we get into this, and I'm really trying to be very sensitive that this is not just a conversation between you and I, that there will be hopefully thousands of people listening to this, because this is such an important message, that the type of approach, first of all, that we take really requires engagement and may require change. And as the expression goes, change is hard. So we're very used to going to the doctor, and really the most in general we're asked to do is take a pill. Go home, don't do anything different, just take a pill, right? And we know how that generally goes. But so first of all, it is important that when people get involved with me, that they're open to these types of changes. Now, in respect to nutrition and change, the other piece of it is that through the principles of effective coaching, we kind of have to meet people where they are. We have to nurture their way of thinking in such a way that they don't feel told what to do. They feel motivated to make change. They want to do it. They feel that, and I use that word very intentionally because we make heart-centered decisions, that this is something they will and must and can do. And then we do it incrementally. But ultimately, what is the direction and what is an anti-inflammatory diet? Well, the most well-researched and most well-published diet is called the MIND diet. So MIND, that's an acronym, of course, but it's a clever one because we're talking about the brain. But it's basically what we would call a Mediterranean-style diet, limiting things like, we want to limit refined carbohydrates, things that quickly become sugar, emphasizing the fiber, lots of vegetables, things like that, lots of colors, those polyphenols, the flavonoid, a family of micronutrients, phytonutrients, lots of polyunsaturated fatty acids, right? And monounsaturated. So everything from olive oil and avocado oil to eating things like fatty fish like salmon and mackerel, anchovies and sardines and herring and so forth. But I really think that we're a meat and potato society, and I always tell people, flip it around. Well, not potatoes, but you go to a restaurant and you say, I want the sirloin steak, and you get this beautiful, whatever, dry aged, whatever, and it's one sprig of asparagus, right? Like, wow, that's your vegetable, one sprig of asparagus. So I say, you got to have a plate of asparagus, and you have 5-6 ounces of protein if you want. We always say the size of your palm. So lots of vegetables, greens, colors, the cruciferous family of the sulfur producing vegetables that increase levels of glutathione, our most important antioxidant. So fundamentally, that is the diet. We do follow a sort of an elimination diet in which our patients are asked to give up sugar. They're asked to give up things like peanuts and soy, at least the conventionally raised GMO type soy. They are asked to give up corn. It's not a vegetable. It's a grain. They are asked to give up dairy and gluten, at least initially. My feeling about gluten is not everybody necessarily is reactive, but there's just not much nutrition value in grain. And I always think of the movies you see, the sort of medieval depiction movies where they're throwing the bread out of the carts to the poor people. You want to eat like the king, right? You don't need to eat the bread. Dairy, there's some cross reactivity with gluten, as you probably know. So, and it wrecks a lot of people's guts. So at least the A type dairy, we ask people to eliminate. We may do some reintroductions later on. Eggs can have a lot of nutritional value, but we ask people to get rid of those foods that commonly trigger reactivity and sensitivity in folks initially. But in the end, it is truly about nutrient density, right? Real food doesn't have a label need a label to tell you what it is. Nutrient density is key. keeping those carbs relatively low. I've never seen somebody become a diabetic because they eat a lot of salad, unless they're pouring some junky dressing on it. Ketosis, we talk more about that. But my opinion is ketosis is a tool. It shouldn't necessarily be a lifestyle that has no end in sight.
Yeah, that's super interesting, and I'm glad that you finished with that because that's probably somewhere that I'd love to just dig into a little bit more. I know, certainly with fasting and fasting mimicking, we enter ketosis, but it's not the primary goal, right? And so I also find myself talking about ketosis all of the time, but specifically as it relates to brain health and cognitive health, you hear the ketogenic diet come up so much in that area. So can you share a little bit about where that's coming from and why there is such a push here and how you feel like it should be used, if at all?
Yeah, well, there's no doubt. Dale Bredesen has his own way of doing things, and that's great. But do want to borrow one thing from him and just know that what I'm about to say is not necessarily broadly accepted, but I think it's a framework for discussion. And that is that he talks about subtypes of Alzheimer's disease, and he's got I think he has it like atrophic or something like that. And then he has his sweet or his glycemic, and then he has other things. But the point is that we do know that at least well, first of all, we have this epidemic of metabolic disease, of metabolic disorder. And we know that there's a direct link between things like insulin resistance and dyslipidemia and hypertension and the waist to hip ratio and all that stuff that defines metabolic disorder, and very much a higher risk of developing Alzheimer's disease. So the point I'm getting to is if we're really practicing precision medicine, we should be able to easily or more easily identify the folks who have brain insulin resistance, right? And in those cases, it really makes sense to optimize fat as a fuel for the brain, burning ketones, if you will, in the brain. Does the person who has not even remotely been insulin resistant yet develops Alzheimer's, like the patient, the Marine I was referring to earlier, need to be in ketosis? I think that's a valid question that needs to be answered, because we tend in general medicine and research to study large populations, right? We'll do a clinical trial of 500 people, but we don't use those precision medicine principles to say like, oh, well, we're only going to study the people whose brains have insulin resistance. We're just going to lump everybody together and then put them on, say, a ketogenic diet, and lo and behold, they do well. But does everybody really need to do that? And are there trade-offs potentially for some people? Because again, we're shooting our arrow through the middle. We're talking about averages. How does the group do? But how does Renee do? Or how does Ken do? That's a very different question. And so I think when we're practicing individualized patient-centered medicine, precision medicine, we can then also be individualized in what nutritional approach might make the most sense for that one person. But yes, ketones, and Dr. Bredesen certainly isn't the only one who's been interested in ketones. I have a colleague, basically, who was a resident with me at University of Virginia, is now up at KUNC in Kansas City, Overland Park. And he did a study a few years back with a ketogenic diet and showed that putting people on into ketosis improved their cognitive scores as much as the most commonly prescribed drug called donepezil for Alzheimer's disease. So people do better. Does everybody do better? Well, you know, if you're starting with what we call the standard American diet and they say, drop everything, you have to do a ketogenic diet, then you're probably setting that person up for failure as well. So I think, again, we do need to really think about practical terms. How do we actually apply this in the real world setting, which is very different than a research study or very different than trying to take the same template and apply it to everyone the same way.
Absolutely. And amen to personalization. Could not agree more. I think we're really starting to appreciate that. And it's so important across the board, across all different medical practices to get that personalization. But you mentioned to be able to assess brain insulin resistance. Now, insulin resistance, I think we are now starting to really test this, but it seems to be more of a whole body approach. Is there a way to really pinpoint brain insulin resistance?
I'll be honest with you. I imagine there probably is, probably using some of the like functional MRI, but I don't know. I'm certainly that's a research tool. That's not something that you can just go to your local imaging center and figure out. So I would say, again, if somebody's coming in with metabolic syndrome, which is going to be probably the majority of people who develop Alzheimer's disease, then, potentially utilizing either exogenous ketones or ketogenic diet or something in between, intermittent fasting, time restricted eating, several rounds of Prolon, right? Which all have value. And of course, all are evidence based.
Beautiful. And a beautiful jumping off point to talk a little bit more about the role of fasting and fasting mimicking that you leverage in your practice. So when are you using these tools? When do you find them appropriate? And what are you seeing in terms of outcomes?
So I would say it would sound like a broken record, but very individualized because Prolon, I've done probably 7 or 8 rounds of Prolon personally. I remember the first time I ordered a kit and arrived, and I think the biggest thing I was worried about was being hungry. I don't know what your experience has been or what other people talk about, but I would say that the hunger part is there from time to time. And I've never had an experience other than on Prolon where I've looked for that last flake of quinoa at the bottom of a soup bowl. But at the same time, I would say hunger really wasn't a major problem. It really wasn't. You have to hydrate, obviously. And once you're in ketosis, it's a lot easier. I would say it's kind of a spiritual journey in a lot of ways. It is a lot of learning about yourself, about why you eat, when you eat, how much you eat, what are the motivations to eat. Because you start eating these very small meals, you're like, and especially the first day where it's 1,300 calories or so. Maybe it was 1,100 or 1,300. But the bottom line is like, that's a lot of food, believe it or not. Like if you're doing it for the first time and you do day one, you're like, oh, this is going to be so easy, right? And it does get a little tougher. I think by day 5, I'm like, okay, I'm definitely ready for this to be over. But that's because we live in a society that we're surrounded by food messages all the time. And we've learned, my wife Valerie and I, we do our Prolon from Sunday to Thursday. That's the best days because never try to do Prolon on a Friday night or a Saturday night, right? But to your question, then, so I have to say, do I do Prolon with everybody? No. Do I do Prolon with some of my patients? Yes, of course I do. And I'm looking for the ones who have metabolic syndrome in particular, who have mastered some of the basic principles of what we want them to learn. Because if they're not ready to at least do we call it our brain tune-up diet, but it's essentially the Mediterranean diet, a modified Mediterranean diet, low carb. If they can't do that, then Prolon's going to be very, very tough for them. So I consider it a more advanced option. I want them to get their foundations first. And then we're looking at insulin levels, blood insulin, of course, not brain, looking at fasting insulin levels, hemoglobin A1C, fasting blood sugar, all the normal metabolic parameters. And I say, you know what? If you feel, you've gotten so far, you've done a great job, you want to take it to the next level, you want to get that insulin level down even further, let's give this a little bit of a nudge with a few rounds of Prolon. So that's kind of where I fit in it.
That I think that makes a lot of sense and finding the right place to put it within the patient journey. I'm curious what your thoughts are because there is some preclinical research that came out several years ago with fasting mimicking for in Alzheimer's models, specifically showing removal of beta amyloid plaques and some regeneration even in cognition, things like that. So, granted, it is preclinical, meaning for anybody listening that it is in mice models. So yes, it is still early research, but what do you make of that and how do you see that playing into this possibly for our human patients?
Well, again, I totally agree with you and understand that we need to couch this in this is research, this is investigational, that kind of thing. We've already established that amyloid really is a cellular response to inflammation. And what is inflammation? What are the signals that drive inflammation? Well, it can be anything from disrupted sleep, like sleep apnea. Very nice studies have been done with college students. Well, they don't have sleep apnea. Why college students? Because college students, first of all, they all need money, and they do crazy things like stay up all night and cram for tests. So you can pay a college student to be sleep deprived and then measure amyloid levels in their brain. And then you can have them sleep and repeat the amyloid test, and all that amyloid clears. And we know it's obviously much more serious when there's disrupted breathing during sleep. So sleep will do that. Standard American diet, enough said about that. We know that that will drive amyloid accumulation. You know the term diabesity, so it's all connected. Movement, well, there's the old expression that sitting is the new smoking. If you're not moving your body, then you're really at risk for being in a much more inflamed state. And we do live in a high stress. And then how we sort of, I don't have any illusion about the fact that, we're not going to all become, monks living in a monastery to remove the stress from our lives. Although I think for any of you who watched White Lotus, you probably know they can be just as stressful. But anyway, the reality is just first of all, do you have a stress resilience practice? Do you take time for yourself? Do you have a walk in nature, read a book, prayer? Doesn't mindfulness-based meditation, Tai Chi, it doesn't really, it has to resonate with you. It doesn't really matter. My wife, we are not Catholic, but I say this because I'm familiar with, counting the rosary. And my wife pointed out, you know what? When you're doing that, that's a form of meditation, really. You're just, counting the rosary, counting the beads, right? So if you're a Catholic and that works for you, that is a form of mindfulness, right? But we have to do that because we're in fight or flight so much in our lives. And if we can have some balance, and that can be measured through things like heart rate variability. We can measure that, and we can say, okay, there's good balance between your sympathetic and parasympathetic nervous system. All of those things drive this amyloid. And to be clear, while we're on in a podcast now with the makers and creators of the fasting mimicking diet, Prolon, if you're just doing the diet, you're not doing enough, to be clear. Right? You have to have the sleep. You have to have the social connection. You have to have that mindfulness, whatever that works for you there. You have to move your body. You have to address your hormones. You have to remove toxins from your environment, right? Just this past year, the federal government banned a compound called trichloroethylene. And if you look up trichloroethylene, you'll have an OMG moment because it is in everything from household chemicals to personal care products to industrial situations to dry cleaning. And in one small study of Parkinson's, exposure to trichloroethylene was associated with a 5-fold risk of developing Parkinson's. And I have patients who are attorneys, and I think of what is the attorney uniform, right? Nice suit, nice tie, press shirt or a dress, right? Everything, they have to look very professional, ideally, typically, right? Especially if you're a big city attorney, I guess. And so they're dousing themselves in trichloroethylene every single day. They get Parkinson's. Not surprising. It's like our farmers get Parkinson's. Why? Because they're exposed to herbicides, pesticides, and so forth. So we know the things that put us at risk, whether we're talking about Parkinson's or Alzheimer's, and we can eliminate those risks and try to prevent those diseases. But there is definitely still opportunities, especially in the early stages of the diseases, to address those things and to reverse the decline that disease represents.
Wow. I mean, that I always find those moments to be these aha moments, but also quite terrifying. Would what is your recommendation when it is so pervasive and seemingly everywhere? How do people limit those or avoid those as best they can?
And I'm very much a practical person and a realist. And there's, by the way, and I'm sure you're familiar with it, a term applied to food, which is orthorexia. It's like you become so obsessed with your dialed in diet that you actually ramp up your stress and make it worse. I once heard, I think it was Peter Attia, I'm sure you know who he is, talk about at the time his daughter now may be quite grown up, but she was young. And he was saying, they go to her birthday party and she says, Daddy, will you have a piece of my birthday cake? And he's a guy, like to be in ketosis, at least at that point in time all the time. But anyway, he would eat a piece of birthday cake. I'm like, what is it? Marie Antoinette eat cake. Right? Of course, she had her head chopped off. But the point is that you're not going to keel over if you have one slice of your daughter's birthday cake, but it's being more mindful on a daily basis. What are you putting in your body? What are you exposing yourself to, right? And putting yourself first. If you feel like you got to have that Coca-Cola every single day, and we know that soda consumption shortens the lifespan by at least 5 years. Regular soda consumption lowers people 5 years earlier, right? I mean, who are you serving? Are you a stockholder in the Coca-Cola company? I mean, you got to think of yourself as that important. You're an important person. You're the most important person out there, and you don't need to do that to yourself. And you have to just shift your thinking and saying, put a skull and crossbones in your mind on that Coke can, because you wouldn't drink a can of poison. And if you use some, just mind games with yourself and say, every time I look at a can of Coke, I see a skull and crossbones. I think the most disgusting thing I could possibly drink, and then I don't drink it because it just tastes bad, right? You got to give that stuff up. You got to give it up. I can't even tell you the last time I drank that kind of thing. And so those are the steps. We got to, be realistic with yourself, be fair. I think sleep is one of the easier things. Just set yourself a schedule. Say, I personally go to bed at 10:30 p.m. Now, some people might be 8 p.m., 8:30, whatever. I go to bed at 10:30. My alarm goes off at 6 a.m. I give myself that 30 minutes of, whatever. So I'm getting 7.5 hours of sleep. If you can do 8, that's great. But I'm scheduling my sleep. If you might have sleep apnea, get tested, right? Adopt a diet. Eat the edges of the supermarket, as the expression goes. You don't have to be a dietitian. Just eat real food, right? It's like Michael Pollan talking about the foods on all the aisles and the cereal boxes that, scream with marketing messages and show the farmer and the pitchfork and all that, right? But there you have the lettuce, the kale, the carrots, the radishes, the cucumbers. They don't need any of that. They don't even need labels to tell you what they are. So you eat the edges of the supermarket. Move your body. If you're not used to doing that, just go out for a walk in nature. You don't have to do anything strenuous at first. It's nice if you can add some effort in there, a little intensity in there if you're physically capable. But if you haven't been doing it, getting out and walking in nature, it combines mindfulness, combines connection to nature with movement, right? And improves insulin resistance. And then do it with friends. Make friends, socialize. There's lots of literature on loneliness and brain health. And, we've had a Surgeon General come out and say that loneliness should be a public health priority, that it is an epidemic. We have a lot of lonely older adults. I would maybe a gender bias, but I would say maybe more with men than women. Women naturally tend to come together. Men don't as much, but there are plenty of lonely women, especially widows probably, right? And women tend to live longer than men. So find your community, find your people. Doesn't matter. Church, club, if you have friends, and call them. And Facebook, by the way, does not count. Real connections, right? Real connections. That's what the blue zones are, right? They're communities all around the world. They eat different things. The Okinawans don't eat the same things as the Sardinians, but they all have community. They all have community and purpose, right? They know why they woke up in the morning.
Absolutely. And I think what's really, eh, I think, helpful to think about here with what you've shared is that there are so many things that you can do to support your cognitive health. And so while you might not be able to achieve every single one of those things today, taking a step in the right direction in any one of those is going to be beneficial. And now, certainly, of course, if you start tapping them all, you're even in better shape. But taking a step in the right direction, and you have so much opportunity and so many ways to support across so many different lifestyle areas. Now, before I let you go, I did want to touch on one more area of your brain tune-up program, which is neuroplasticity training. And I think this is something that we don't really hear of very often. So can you share what that is, why it's important? What do we need to know?
So in reality, we do neuroplasticity all the time, most of us, right? Anytime you learn something new, acquire a new skill, a habit, anything that you change in your life really changes your brain. But I tell my patients an old one-liner. So I don't remember which, comedian of many decades ago first told this joke. This guy hails a cab in New York City, and the cabbie, slows down. He rolls down his window, and the guy sticks his head in the window. He says, "Hey," he says, "how do you get to Carnegie Hall?" And the cabbie looks him in the eye and he says, "Practice, my man, practice." Right? That's neuroplasticity in essence, right? Making new habits, learn a language, play a musical instrument, do something different, change it up, you know, creating these connections in the brain ultimately is neuroplasticity. Many people are familiar broadly with a stroke, where it's a blood clot in the brain that has cut off oxygen and blood flow and nutrients, and that person actually loses a whole section of their brain in the context of stroke. And so the people who have the big strokes are often paralyzed, maybe all the way down one side of their body, maybe even losing their ability to speak. And I'll tell you a little bit more of that. I know we only have a minute or two left. I'll tell you more about that in a moment, but there's a type of physical therapy rehabilitation. I don't know how commonly it's still used, but it's called constraint-induced movement. And it used to be that if you had a stroke and you couldn't use your right arm, you go to therapy and they teach you how to better use your left arm, especially if that's your non-dominant arm. Then suddenly you have to use it for everything. Not in constraint-induced therapy. In constraint-induced therapy, they put a mitten over your good arm. They say, okay, now take this cup and this pitcher of water and pour it into the cup. And you're like, well, I'm going to spill it all over the place. Like, yeah, you probably will. But guess what? It works. You have to do it over and over and over again, but eventually the brain figures it out and rewires itself, neuroplasticity, but you got to give it food, you got to give it sleep, got to give it some hormones, you got to give it movement, and it will do it. I know you can see pictures on the wall behind me, and if I turn my camera, there would be a picture of one of our nation's poet laureates. His name was William Meredith, and I met Bill Meredith back in 1986, approximately the year after I graduated from college. He was still living in Washington, D.C., and he had been a professor at the University of Connecticut, but he was one of our nation's greatest poets. I was interested in poetry and literature, and so I was living in D.C. at the time, and I was introduced to Bill Meredith. And when I was introduced to him, the person who introduced me, by the name of Henry Taylor, who's a professor at American University and himself a Pulitzer Prize-winning poet, said, hey, I know you're interested in the brain and neurology and all that. Well, I have this friend who had a stroke, and he needs help getting to all of his appointments, his speech therapy, physical therapy. Could you, if we paid you, would you work with him? And I was introduced to Bill Meredith, who had had a stroke. Ironically, his greatest gift, his language, had been taken away from him. Okay? Now, for those of you who Google, and that's probably 100% of you, you can go to Google and look up William Meredith, the poet, and find that about 10 years later, William Meredith could speak again, to the point that he could be on interviews, and he spoke eloquently enough with minimal difficulty, be very intelligible. He got his language back. That is neuroplasticity.
That is incredible. And when we think about, I think people spend a lot of time talking about the liver as the most regenerative organ that we have, but clearly our brain is right up there too. And there's a lot of opportunity to make new connections and leverage that to our benefit. So what an incredible story. And thank you for sharing that. And I guess to close us out, is there anything else that you're maybe really excited about in this space? Anything else that you think that the listeners should know in this world before we close out for the day?
Well, first of all, I want people to have hope. And unfortunately, there was a recent article in the New York Times that really, unfortunately, was not evidence based and was very anecdotal, which is a very bad way, a bad, we are captured by individual stories. Of course, we're captivated, but individual stories are just that. They're individual stories. And we have to understand that we are in a day and an age and a future where Alzheimer's disease is reversible, where Parkinson's disease is reversible, where multiple sclerosis can be put into remission, and that a person can live their entire life pretty much as they want to. Despite having, say, multiple sclerosis. So there really are opportunities, but you have to first and foremost adopt that frame of mind that, okay, this is a hurdle, this is a challenge, but it's not insurmountable. And I'm going to connect with the people who know how to do this. And there's more than just me out there, though, not enough of us, but find that practitioner, make sure they have a good reputation and they really can do what they say they can do, and know that you can do it. You can do it. You can improve. Are we always curing the disease? No, we're not always curing the disease, but we know that we can reverse cognitive decline. We can give people more quality years. We can, in some cases, reverse it. And in some cases, we take some very aggressive diseases like ALS, which has a 50% 2-year mortality, and we can have people that are living 10 years with ALS. By the way, like Roy Walford did. 10 or 12 years. And although people may not know, I know you know who Dr. Walford was, who ultimately died of ALS, I truly believe that although it might seem ironic on the surface that one of our greatest pioneers of longevity and understand the biology of longevity would have died of ALS, but he lived far longer than the average person with ALS. And I truly do attribute that to all of his work and sort of being his own guinea pig, so to speak.
But you just prompted me to think that we should do an episode on Roy Wolford and talk about the biosphere and everything, all the incredible work he's done. So, yes, absolutely. But back to you, because I want to make sure that everybody knows where to find you if they want to learn more. This was so insightful. Thank you so much, Dr. Sharlin. Tell our listeners where they can learn more from you and connect with you.
Well, first of all, I'd love them to visit my website, which is functionalmedicine.doctor. So it's not .com, it's .doctor, and you spell that out, DOCTOR. We do have the Facebook and the YouTube channel and the Instagram and all that. But start with our website, and there's an opportunity on our website to sign up for a complimentary 15-minute phone call. We can learn a little bit about you, and usually, quite honestly, those end up being much longer calls because, you know, these are complex problems and we want to be able to help. So go on there, sign up for a call, learn about us. I do have a couple of books. They're available on Amazon, Barnes and Noble, The Healthy Brain Toolbox, as well as our food guide. So you might want to pick up a copy of my book. You can get it on the website, our website as well. But yeah, check out the website. It's a great place to start because honestly, we want folks to have that, what we call pre-education. We're doing this right now. We're teaching people so that by the time they pick up that phone and they're talking to my functional medicine coordinator, they have a reasonable idea of what's involved, right? Because if you're not, going back to our earlier conversation, we want people to be knowledgeable and ready. We're putting you in the driver's seat. And if you haven't read the little book and done your practice, you're not ready to drive the car, right? We want you to be ready to drive the car and work with us.
Well, it is so great that you are offering those resources for people to take that first step because oftentimes that first step is the hardest one. So even just finding a place where you can get that 15-minute intro call, how incredible. So thank you, Dr. Sharlin, for giving us all of this time today, for sharing your knowledge. And we very much look forward to staying in touch and hearing more from you in the future, which I'm sure there will be continued questions from our audience from everything that we chatted about today. So thank you again. And thank you to all of our listeners today. We will see you on the next one.
My pleasure. Thank you.